Hello, and thank you for joining our discussion today. We are excited to be a part of the Rock Health Summit virtual panel series. My name is Sahi Abdelmomen, and I'm the virtual health strategist at Tulsa Innovation Labs and your moderator for today's discussion. We're excited to jump into our discussion around the impact and potential for community healthcare workers. Today, the country is facing declining national life expectancy, severe racial health disparities, and a growing provider shortage. These pressures are pushing healthcare leaders to explore new systems and talent pools in hopes of building towards adequate healthcare for all. Zip code and race have become the strongest predictors of health outcomes, and patients want and deserve more. The silver lining is healthcare providers and startups want better as well. Today, for our discussion, we are joined by Jabran Pasha, Vice President of Health Equity at Juno Medical, Cameron Matthews, Chief Health Officer at City Block Health, and Colby Takeda, co-founder and CEO of PearSuite. To kick off, I'll provide a brief overview of the work that I do at Tulsa Innovation Labs, and then I'll pass it off to our panelists to provide an overview of their organization's mission and their role in that mission. Tulsa Innovation Labs is a tech-led economic development organization that's backed by the George Kaiser Family Foundation. At Tulsa Innovation Labs, we design and deploy programs that enable startup support and development, intellectual property development, as well as workforce support and development. I will now pass it off to my fellow panelists to share their background and provide a little color to their organization's mission and their role in that mission. Colby?
Thanks so much. Hello, everyone. My name is Colby Takeda, co-founder and CEO of PearSuite. I was born and raised in Honolulu, Hawaii, and worked in senior living for the early parts of my career, helping older adults navigate the complicated challenges of getting older, while also finding local resources. I then worked for the Blue Zones Project by ShareCare, specifically on the policy and partnerships team, and led that across the country to better understand how the resources in the community tie with policy changes to improve the social determinants of health, everything from access to healthcare to transportation options, safe parks. I'm looking at food resources, housing, education, everything in between. I then launched PearSuite after teaching community health worker courses. And so I was an instructor in Hawaii during the pandemic, really understanding what are the gifts and challenges and experiences that community health workers bring to the table. We recognize a need to scale up the work of community health workers, help them get better data, and launch this work over large organizations that sometimes didn't have a good system of tracking data, which is why we launched community health workers through our community, both through our services arm of PearSuite, but also through our SaaS platform. Now our mission is to empower community health workers and community-based organizations through our care navigation platform. Excited to be here. Thanks so much for having me.
Thank you, Colby. Cameron?
Thanks so much for having me. My name is Cameron Matthews. I'm a family physician by training, and I'm Chief Health Officer with City Block Health. I've had the real fortune, actually, to work in multiple different environments with marginalized communities, and I really consider it an honor to be part of this transformative practice that City Block is really leading the way with. We are a startup at its nature and really seeking to be, again, transformative in value-based care, particularly for Medicaid and low-income Medicare beneficiaries. By focusing on marginalized communities, our very mission is actually focused on health equity, where we are really seeking to implement the basic standard of care in an integrated primary care practice, and to really improve the outcomes of care for those communities that we serve and that actually need it the most. We partner closely with community-based organizations and health plans, as well as our provider network colleagues, to build trust, most importantly, with our members and deliver comprehensive care, medical care, behavioral health, as well as social services through multiple modalities, not just virtual, but also in person and in the community.
Hey everyone, I'm Jabran Pasha. I'm an internal medicine physician and VP of Health Equity for Juno Medical. Juno Medical is also a health tech startup founded in 2020 with a mission it's a grand mission. It's to simply create a healthier world. And we look to do this by designing healthcare for the communities who have been overlooked and let down by healthcare historically and currently. We feel that for most families, the mother is the chief health officer of that family, and we look to make it easier for whoever that chief health officer is to take care of their family. And so that is providing a healthcare center that doesn't feel like your traditional healthcare, providing a healthcare center that has diverse clinicians and staff, providing a space where you can feel heard, you can feel truly cared for. My role is twofold at Juno. As I mentioned, I'm the VP of Health Equity, really with the goal of just holding us accountable as an organization to see that for every decision we are making, we are considering the impact on health equity. As the medical director for our Tulsa clinic, which is in historic Greenwood, we have brought care to Greenwood District for the first time in 50 years. And that's against a backdrop of the Tulsa Race Massacre. And so we're in a community where there is racial division. We are in a community that has a strong need for healthcare. And we are in a community where there is earned distrust for healthcare. And it is our responsibility to bridge that gap. And we feel if we can do this in Tulsa, we have a really good blueprint that may work for other communities as well.
Thank you, Gibran. And with that, I'll segue right into the first question of the discussion. As I mentioned at the beginning of this discussion, the country's in a place where it's facing declining health outcomes due to inequitable healthcare access challenges and a growing provider shortage, as well as a lack of SDOH interventions. How is your organization navigating these challenges, and what role do community healthcare workers play in that equation?
Yeah, I can take that. I, feel that as an organization, if we're going to be successful, we really have to understand what truly shapes health. And we have to realize that relative to the time that someone spends receiving healthcare at the point of care, they spend much, much more time out in the community. But unfortunately, the vast majority of the $4 trillion that we spend on healthcare is at the point of care. And so what we are trying to do is really start to divert some of the resources from the point of care to where the patients actually need it most. And that's in the community, right? And so one way that we are utilizing community health workers will be in remote patient monitoring. We're leveraging the tech that exists. We know that patients don't always have to be in the doctor's office. They don't always have to be in the hospital to be cared for. And so via remote patient monitoring, we are utilizing LPNs. We plan to utilize LPNs and even maybe medical assistants to help become navigators, right? To interpret the data and then to act as almost like community quarterbacks with those patients to make sure they're getting the care that they need, both synchronously and asynchronously. Another way that we are impacting care in the community utilizing community health workers is through the development of a behavioral health collaborative in which we are going to utilize community health workers as licensed clinical social workers to help our patients with mental health conditions actually navigate the very difficult process of getting behavioral health services. And so this community health worker that we're going to utilize across our markets not only is a therapist, but also is a social worker, right? And so they are truly trained to help bridge the gap between patients and social services and other mental health needs.
Yeah, I can just jump in and community health workers have been around for decades, and I think they got a lot of excitement around them during the pandemic when they're utilized to engage resources in the community, support with vaccination and testing, and there was a lot of money invested by the Biden administration. But because they've been around for decades, we have to really capitalize on their experiences and their connections and their understanding of community resources. I think community health workers are amazing, connectors and understanders and listeners. But I love going into a room of oftentimes providers or even health plans and asking the room, like, who here knows what a community health worker is? And I'll ask you to raise your hand, and literally like 5-10% of people actually do raise their hand. And so first we have to start with helping to elevate and uplift this workforce. These are people that have been doing this work for decades and decades, and sometimes haven't gotten the recognition they deserve. Understanding that they have special skills and talents and values that really can help the healthcare system advance beyond just providing cures for sicknesses and really promoting health and well-being. But of course, there's also some challenges with policy and regulations and regarding reimbursement and paying them. I think there's a lot of a big understanding that community health workers oftentimes aren't paid what they deserve. So helping them find fair wages to support with their current lifestyles and help them live in a safe and secure setting, but also looking for paths for career development and growth. From the beginning, when PairSuite launched, we made it a point to bring community health workers not just onto our team, but put them in leadership roles. Some of our key leaders have come from the community health worker space or are community health workers themselves, and giving them the tools to be successful and helping to co-design our platform to ensure that we are incorporating their voices and their skills and their workflows into our development and our training has been key for us. And as much as we have amazing people on our implementation team that came from big companies like Epic and Athena and whatnot, we want to make it so that community health workers are the ones training and helping other people understand the needs and interests and how to use our system. But certainly there's a lot of opportunity, but also a lot of challenges. And so we're excited to continue talking today and sharing more about how we can overcome some of those challenges together. Thanks.
Thank you, Colby. You and Jabron both touched on some points that we're going to dive in a little deeper into the conversation on, but I'd love to pass it to Cameron to learn more about how City Block Health views community healthcare workers.
Yeah. At City Block, we actually call our community health workers community health partners. And so much of that is because we look at them as a partner in the care with the member, as a partner and a full-fledged member of the care team. So the distinction between clinical, non-clinical really makes no sense within our model because we actually put the CHPs out front as the main point of contact, that main really source of engagement with our members and then all the different services that they could be utilizing within City Block. Our CHPs play a pretty important role in just building that initial trust of that initial outreach, those initial conversations, so that we can really ground our members in similarities and connections. We purposefully, of course, recruit our CHPs from where our members, live, work, pray, and the like. And they are even a part of the goal planning. So it's not just, a clinical set of tasks that a care team prescribes to a member, but we really think about, of course, the health-related social needs, but overall, just kind of companionship and advocacy that member may need. And the CHP is a pivotal piece to making sure that the member, more than anything, is connected to that. Our CHPs go across all of the different modalities that we use. So they're actually in the hospital at times with the members. They're, in fact, through our maternity program, they're providing some doula services. Through our behavioral health program, they're helping with engagement and even some steps into addiction medicine. We really want them involved throughout the continuum of services again, and having a familiar face there to support our members is how we really emphasize the fact that the CHP has to be at the lead.
Thank you. And, knowing that community health workers are central to all of your models, all of your care delivery models, what are some of the outstanding challenges that you guys face with the implementation of community healthcare workers?
Yeah, happy to start off. I think community health workers recognizing their skills in building trust, in understanding the community. Like I said, they've had a long history of doing this, but oftentimes have been taking notes on notepads or tracking things in spreadsheets. And I think the transition to getting data beyond what they usually focus on, and they're really focused on helping their members or clients or their people that are in the community. They aren't as focused on billing and coding, and as much as that's not key to helping the member, it really is key to getting the billing and the coding for reimbursement potentially in some states, or for connecting what they do back to the outcomes that health plans and providers need to see for them to justify and incorporate these care delivery workforce into the model. And so I think transitioning them to technology and helping them potentially with digital literacy challenges, helping them understand that they're part of a bigger picture and that they have to work with other partners. And I think connecting them to traditional providers. So I'd love to hear from Jabron and Cameron about how they can work with clinical providers. A lot of what PeerSuite does is in the community with the social determinants of health. But certainly this has an important part in the bigger picture of comprehensively supporting members in the community. And clinical care is a part of that. And so I'd love to pass it to Cameron and Jabron to talk about how they can best incorporate community health workers in the social determinants of health with clinical outcomes, because that's really key to solving some of our bigger health challenges and overcoming some of these billing codes and reimbursement models that require clinical outcomes to justify the expenses for community health workers. Thanks.
Yeah, I think as PeerSuite obviously realizes, community health workers have been in the community doing this work for a very long time, and I think it's really important for larger healthcare institutions to realize that they don't have to reinvent the wheel. Right? They don't have to redevelop these programs. There are boots on the ground organizations that are doing this well-needed work. They've been doing it for a very long time. They already have the trust of the community. And I get why City Block refers to them as community health partners. We really have to learn to partner with these organizations. And that saves a lot of resources, right? You're not having to stand up these programs because they're already stood up. And so kind of overcoming that general thought that you have to create these programs. There are a lot of them are already created. And the other part is just making sure that people see the benefit. And by people, I mean the patients. I mean the clinicians. I mean the payers and the administrators, to help them find the value. And as Colby is alluding to, oftentimes the only way to really show the value is through research. And we really need to continue to show our work and show the outcomes via research to really justify what we already know is useful, and that's leveraging the knowledge of our community health workers.
Jabron, I love what you said. I think so many times when we're talking in this innovation space, the typical discussion is focused around, the brightest and the shiniest and the newest sort of opportunity, whether it be tech or a service or the like. But sometimes innovation is just doing what has already been done for a different population in a different way with incremental change, and I think that's exactly where both of our organizations are coming from. We're providing strong primary care to communities that are facing inequities. We don't need to recreate the evidence that providing good primary care will solve those inequities, and CHPs are a significant part of that. So you're exactly right. There hasn't been a need to recreate. It's really about reconsidering, which members of the care teams need to be providing which services. It doesn't always, in no way, does it always need to be a doctor. And in fact, we are really should be taking more of a back seat, particularly in the space where we're trying to engage and really involve the member in their care. I think for us, really the combination between our nursing group and our CHPs to provide that kind of longitudinal connection, to provide education. We do a significant amount of education through our CHPs, and so therefore have fun in training them up in order to do so. That's really the place where we're hoping to help them flourish as both individuals and kind of on the larger scale. And we're hoping to show that data as well, too. I'm glad you brought that up. I think the one thing I'll just add, because I completely agree with with all the comments around challenges, especially Colby. What ParaSuite is trying to address from a documentation standpoint. My goodness, we just flipped to new EHRs. So thinking about, how much we have the CHPs in there versus our other systems, that could be a whole nother set of webinars. But for us, one of the challenges that we have to remember that really what the rest of the healthcare workforce is facing is just as equally applicable to our CHP staff, and that's burnout. That's setting healthy boundaries. That's making sure that they are, prioritizing their own care and well-being as they're caring for, members of their community that require a great deal of attention. So we are equally as invested in involving them in conversations around their own health, so that we can, maintain city folk health as well as the members that we treat.
Interesting. And Cameron, that touches sort of on the next question around how do organizations like City Block Health train and prepare community healthcare workers for some of the challenges that they face? Because, like you said, you want to make sure they can take care of themselves while taking care of their community. I'm very interested to learn more, Jabron and Colby, about how your organization sort of views training and preparing community healthcare workers.
I can jump in there quick first. All of our care teams, and that includes community health workers, community health partners. We have an obvious focus on trauma-informed care. We have a focus on cultural humility, even cultural fluency, we like to call it. So larger concepts about really strong communication and making sure that communication is actually beyond just the relationship with the member, but communication as a care team, right? They're trained on our care model, so that they understand what the interaction of their particular member, their panel of members, what those interactions are with the physicians, the nurse practitioners, the psychiatrists that we have. And we really try to orient them to really the larger environment in which we're hoping to help the members. So we're involving them in case conferences. They're at the table having the full conversation as a member of the primary care team. So with their onboarding into the organization, we need to, of course, get them comfortable in that space. And they're proving to be quite successful and more helpful than anticipated in a lot of respects.
Yeah, I would echo. We have a very similar approach at Juno, and it's the approach that no matter what role you play at Juno, you get intensive in-person health equity training. And so that's the expectation for someone who is doing billing. So it's obviously the expectation for someone who is patient facing, like a community health worker. We make sure that all of our team members have training on the impact of bias in healthcare and learn mitigation strategies. We make sure that all of our team members get cultural humility training and medical documentation training to make sure we're documenting in a very non-stigmatizing way, and also training on social determinants of health, or those social drivers of health, which is why we're having this whole conversation here today, because we know that they impact health in a much more significant way than the actual point of care, right? And so that's part of it. The other part is the whole question of who meets criteria to be a community health worker, right? And I think it's understanding that it depends on the role. And we have to walk a fine line. We have to be really careful, because traditionally marginalized groups often have access to clinical workers who are lesser trained or potentially of lower quality. And we do not want to continue that trend. And so we do have certain expectations to maintain the excellence that we maintain for our clinicians and for our MA staff and anyone who has patient care access. And so that's the line you have to walk, and we want to get it right, because we want to be inclusive, but we also want our patients to get the high quality care that they deserve.
Yeah, I'll say beyond what everyone's been saying, I think there's a lot of important connections between what community health workers do in the community with the social drivers of health with clinical outcomes. And so how do they tie some of the impacts around food and housing and education and digital literacy to getting their annual wellness visits, or being adherent to medication regimens, or being able to know when they can reach out to an urgent care versus going to the ER. And so being able to recognize that those transitions of care, there's a lot of money right now being invested in community health worker training, and it's readily available both online at community colleges, at different training hubs. I myself took a course and went through a program, and I encourage everyone else, if you haven't explored what a community health worker is and what training they receive, I encourage them to take the classes. It's a lot about understanding needs and asking the right questions and doing case management. And it's essentially, as like the things you would learn becoming a social worker, you get to have a brief look into. And so it's really interesting, but also connecting that to the healthcare side and billing, because there's going to be some key important steps to ensure that we can incorporate community health workers properly. And a lot of it is tied to sticking to the codes and documenting well. And if we're going to upskill this workforce to align better with the healthcare system and payment models, we have to get them to the point where that can be documenting the key codes and help with billing, with tracking time and whatnot.
Yeah. Throughout this conversation, I've heard a few points around reimbursement and billing, and sort of monitoring the time of community healthcare workers, because some of the business proposition challenges that they face. As it stands today, there are only 15 states with Medicaid programs that reimburse for community healthcare workers. This obviously poses a significant challenge in the implementation of community healthcare workers. How I would love to learn from you guys how community healthcare workers complement your organization's business model, and where can tech support in the integration of community healthcare workers into these business models?
I'll jump in. It's an integral part of our business model. Being a value-based care practice, we have the ability to really focus resources and to meet the needs of our members in ways that the fee-for-service model does not support as well, if at all, as you pointed out. So for us, we look at not just our CHPs, but our broader behavioral health staff, our broader tech staff in-house, in fact, just as really an extension of our ability to meet our members' needs when and where we need to. So really, that's where I am. That's why I'm enjoying being in value-based care, because of my just sheer overwhelming frustration in the fee-for-service space before in federally qualified health centers, where we had plenty of staff that served in this function, but voluntary only, and therefore just really difficult to be able to provide that structure that we could, have some integrity to a program as well as measure the outcomes from it. I'm very excited that we can now expand in this value-based space to how our CHPs are actually participating in our clinical support. Like Gibran described, there's so much more that they could be doing beyond just navigation. And so we're hoping to continue to challenge that with additional programs that we design and defining their roles in each of them.
Yeah, and I'd say for us, we are still in a traditional fee-for-service model while preparing for more value-based care and understanding what that means. Developing and integrating, community health workers is going to be a huge part of that, right? And so we are newer to the use of community health workers, and the programs that I mentioned are, getting rolled out in some of our markets, with the plans of, figuring them out to roll them out universally for all of our markets. But we know which way healthcare is going, and it's going the direction it should go, and that's via value-based care. And so it's better to try to get on the right side of it. And that's kind of the approach that we're taking.
So PearSuite is building software just for community health workers. So it's certainly a key part of our work. They're still, even with the 15 states, a lot of these are strictly fee-for-service models, reimbursement. And everyone, I would think, would argue that the rates aren't high enough. The organizations, I was just at a conference at a state where they were all celebrating. We finally have reimbursement. Everyone's happy. Yes, yes, yes. And then the presenter asked in the room, who's actually utilizing the benefit? And it was literally me who raised my hand and one other county. And so I think people have to understand that there's some challenges with the fee-for-service reimbursement model for community health workers. And as much as this would supplement, revenue for a lot of these organizations, a lot of them were small organizations, nonprofits that are doing this work. There's a lot of challenges becoming providers as well. Understanding that there's some regulations around what you can bill for and when you can bill and who can bill for it. Being a provider with health plans isn't the easy thing. So helping to navigate that, even though we have software to kind of simplify a lot of the billing and tracking and invoicing process for a lot of these nonprofits, just understanding what provider status is an important piece. And so I think we're doing a lot of capacity building for these organizations as well, helping them build those connections to other nonprofits and other groups doing work across different social mental health so they can partner together, helping them just understand what the different revenue streams that health plans have access to are and how they can benefit from those. And so certainly overcoming a lot of those things are some challenges that we're overcoming. But we have to go beyond the 15 states, of course. And I think as organizations start to get better data, they can help the states get better rates, and hopefully the rates will lead to better contracting around value-based care. And we can see a lot of these organizations be compensated fairly, and everyone will win together. I think that's the end goal for everyone. Thank you.
Yeah, thank you so much for that, Colby. And we're coming up towards the end of our conversation. I'd love to close this discussion with what message would you like to leave healthcare leaders and startups with when it comes to integrating, SDOH interventions and integrating care that is culturally competent for all?
Yeah, I can kind of start us off on this question. I think one thing that Colby and PearSuite do really well that I hope becomes the norm is just get beyond identifying social determinant issues for patients. There's a lot of software out there. There's a lot of data gathering, but what happens after that, right? And so taking it that next step to help patients navigate those social barriers that they have is the obvious next step. And so I want to, applaud Colby and his team for leading the way, and also encourage others to take a similar approach. With that comes culturally competent or care that's culturally humility, cultural humility and care. So we've got to go beyond just recognizing a problem.
Well said. Well said. I think with community health workers, partners, promotadores in the VA where I was before City Block, we have very strong peer support programs by other veterans. I think we need to recognize holistically that the traditional medical model isn't sufficient, and that we need a broader workforce that is more responsive to the needs of the patients and the communities we're serving. And this is one option. We need to think of ways to make it a more efficient process. So I'll join Ron and applaud Colby for really thinking through probably the largest source of burnout, as I was mentioning. How do we document? How do we make sure that the work that they're doing is appropriately recognized and can lead to future analytics and outcome? I think the next piece that I'll challenge is also how do we, and we don't have the perfect answer to this. We're still figuring this out as well too. But what's the next step of integration, instead of thinking of them, solely in the SDOH space, or even if they step into clinical care, there still can be that separation. How do we bring them in within our teams? How do we think of them as we're trying to promote as full-fledged members of the care team? I'm happy that I actually include our CHPs in our full care management structure. And I think as more states recognize the longevity of this role, of really the importance in order to support our larger workforce needs. I think we need to come up with more, I'll say, innovative ways, but it's not even just innovation. It's just, we're a single team. Let's work together. We don't do that well in medicine, period. So then when you add another role in, it gets difficult. But what additional ways would facilitate that integration? And whether it's through technology space communication, or sometimes it's just, how we actually communicate with the members and think of ways that we could streamline that. I would just challenge us to not think of CHPs, CHWs in a silo, just as much as we're siloed everywhere else in medicine. How do we integrate them into the larger care services?
Yeah, well said, Cameron. And we continue to, at PairSuite, try different models, and there's always some hurdles, right? It's tech integration with EHRs, providers not being as welcoming, social workers feel like their space is being stepped on, not understanding what everyone's role is. We're even co-locating community health workers at FQHCs and other clinics. But yeah, I'll leave everyone with the group with the idea that, community health workers could be amazing parts of your team, whether you're, and PairSuite works with all types of organizations, whether it's clinics, startups, people providing clinical care with med devices, or even doing things like caregiving support. We're really can be added on. Community health workers are that key to building relationships, to really understanding the needs of members and patients, and getting good data, and then actually solving problems in real time. And I think, I would just encourage everyone to explore this as a really economical and trusted, effective, and efficient workforce that can really add to your teams, regardless what sector or division of healthcare you play in. Thanks so much.
Thank you. Thank you, guys. Really appreciate you guys joining us for this discussion. I want to, deep gratitude to Cameron, Jabron, and Colby for providing their insight and their time for this very valuable discussion. And thank you to the audience for joining us for the Rock Health Summit digital panel series. Thank you so much, and have a great rest of your day.